Welcome to dentalxp.com. I'm Dr. Maurice Salama, and tonight I have the pleasure of introducing a dear friend and colleague of mine on a real interesting topic, something that I've been looking forward to, and he's been kind enough to provide a presentation on the treatment of the failing dentition or the edentulous maxilla and different modalities aimed today at treating those types of situations have been highly debated and contested. And George is a periodontist from St. Louis, Missouri. He has lectured all around the world, has a particular practice suited towards this type of dentistry and immediate loading, has been doing it for over a decade, and has been nice enough to share his time with us tonight. And George, I'm looking forward to this presentation. And once you're done, we'll have some time for question and answer at the end. But without further ado, George, it's all you.
Thank you, Maurice. It's glad to be here, and I'm happy to have an opportunity to do a presentation for you and Dental XP and our viewers, who hopefully will find this presentation interesting as well. And I think one of the things that I'm getting a lot of interest in is this all-in-4. Is this a fad? Is this a phenomena? Is this something that is a reality for our patients? So that's what you and I had talked about, and I hope that our audience will find this interesting. So we're going to kind of get right into this, and I'd like to thank a couple people for the sponsorship for this program. First, I'd like to thank Noble Biocare and their global support for myself and this program with Dental XP. And I'd like to thank Bob Salvin and William Simon over at Salvin Dental Specialties, who have helped my practice over a number of years and are really good close friends of mine. So the outline I have is to look at what is the evidence, clinical experience, and patient values. How have my patients benefited from this? And really that's what evidence-based care is about, using these three components to discuss this particular protocol. So why even talk about it? Why is this of interest at dental meetings or dental conferences or Dental XP? Well, in the United States, where I practice, it's estimated that 26% of the U.S. population between the ages of 65 and 74 are edentulous. So that's a significant number of people, and that's just been published in the ADA. There are approximately 2.2 million people that are edentulous worldwide. So I think, you know, the World Health Organization has a particular view on edentulism, which I will talk about as I get into the presentation. Again, we're going to look at what really is the best treatment outcome for these patients. And the question I had early on is all-in-4 really the best outcome? Because you mentioned I've been doing this a while. I was one of the first Brandemark style trained periodontists in the United States in 1985-86. So is all-in-4 something that is a best treatment outcome? And we're going to look at that. I think before we really get into it, there is some confusion with some people on what really is all-in-4. So let's take a look at what it really is, or my definition. It's 4 implants in what we call zone 2, and I'll discuss that in a second with a slide. The two most distal fixtures are tilted at 60 to 45 degrees, and it depends on what axis of tilting. Some people say it's 45 to 30. I like 60 from the vertical. The two most anterior implants are usually vertical, or 90 degrees to the bar that will be fabricated on the final prosthesis. And all-in-4 really initially is a fixed screw-retained acrylic prosthesis that is placed at the time that the fixtures are placed, so it's an immediate load protocol. So that's kind of the definition that I would use. A close friend of mine, Ed Bedrosian, an oral surgeon in San Francisco, wrote a book highlighting, and this is his criteria of zones. He divides the maxillary mandible into 3 zones. There's zone 1, zone 2, and zone 3. So what we're looking at primarily is talking about implants in zone 2, which would be in the maxilla anterior to the sinuses, which is why sometimes we're doing it in the maxilla. And in the mandible, it would be anterior to the mental foramens. So These are slides that are given to clinicians taking courses or getting literature from Noble Biocare showing what all-in-4 would look like from a surgical placement in the areas that I discussed, zone 2. And then we see a fixed screw-retained acrylic prosthesis with no distal cantilevers that's placed at the time of surgery. So I think these slides are extremely representative of what all-in-4 really is. Now, this particular video was provided by Console Pro, and it'll show how this particular procedure can be done. And in this case, what you're going to see is the teeth are going to be extracted for whatever reason. We'll talk about that a little later, why teeth should be extracted. But the teeth are going to be extracted, and we know that if teeth are not replaced with implants, that there will be resorption. The most significant part of the resorption is in the first year to two following the removal of the teeth. And so, yes, all-in-4 can be used at that stage, or it can be used at a later stage of resorption. And this is obviously a moderate to advanced state of resorption in this case. So the video highlights the placement of the two implants that are parallel and 90 degrees to the occlusal plane. Then the next step would be to identify bilaterally the bundle and the mental foramen exit. We know that there are variations in the anterior loop, so those would be identified in radiographs or cone beam CT. And now the implant is placed in a tilt manner, whether it's done analog or it's done with digital computer-aided guides. And so this is what is the hallmark of the tilting. I've done some math on how much tilting affects the AP spread, and we can talk about that in the Q&A. So now the implants have been placed, then we place our multi-unit abutments, which can be 0 degree, 17 degree, or 30 degree angulated. And this would be the final prosthesis with a cantilever. In this particular video, we would not do a cantilever in the interim conversion prosthesis. So it is a screw-retained prosthesis, the final prosthesis with a titanium bar. And I think this is an excellent representation of the entire procedure for a patient receiving all-in-4. So having seen the animation, one of the things that patients commonly talk about is, you know, what is this going to do for me? And these are goals. I think the first is probably the most important. Nobody wants to go without teeth. And if we can lessen patients' disability with dental implants, which is the primary reason we do it, I think that's great. I do consider this to be a minimally invasive option, and it can be done as soon as possible. There is a lot of science and physical and emotional reasons to do this. There's no compromise of the long-term prosthetic outcome that I can see in my experience doing all-in-4. And ultimately, as we'll see in the patient's testimony, it does improve the quality of their life. So I think these are admirable goals that can be met with this procedure. And this is a typical patient that presents to our practice. Some of them come, they are, believe it or not, edentulous and have no prosthesis. They're not wearing a denture. And why? They can't wear a denture, or they don't want to wear a denture, or they don't think they can wear a denture. So we have patients with no prosthesis. And then we have patients who have already lost teeth in one arch, whether it's the maxilla or the mandible. And we have patients in our perio practices and general practices who need to have teeth extracted due to this case of advanced caries, advanced periodontitis, and they might need the teeth removed in one arch or both arches. And then also one of the things that we do is not everybody starts off with all-in-4. They might start off with an overdenture, and it is meeting their needs, but they either would like something better or financially can afford something fixed, and so it's kind of an upgrade. And I think that's important, not to back patients in the corners and allow them the ability to upgrade. And I think all-in-4 can be done that way if the initial implants are put in with that thought in mind. Now, my take on this, and this comes from listening to Dr. Brannemark many times talk about edentulous patients. In today's world, Maurice and I were talking earlier that I was in the Air Force, and fortunately our services who have been involved in war and people lose limbs have been able to replace limbs today. And we have very high-tech ways to replace people's limbs. I've had some opportunity to see veterans who have had these types of appliances, or people who have lost limbs for other people, and we're restoring them to form and function. And when people can ski and play tennis and racquetball, I think this is a wonderful thing for patients to be able to do in our world today. And with dental implants, just like with orthopedic prosthesis, there's many ways to give people their teeth back with implant prosthesis. Carl Misch has been one of the pioneers in this area, discussing his techniques. Paulo Malo from Lisbon, I think, was probably one of the early pioneers with the tilted all-in-4 technique. Tom Balshi in Pennsylvania does a great job with the zygoma implants and pterygoid implants. And then there's a newer program or newer style called V2V, which is coming out of Italy, I believe. Algarari has talked about using implants in a different configuration. So there are many ways to give patients back a fixed prosthetic device to allow them to be whole from a dental standpoint. And in my philosophy, I look at a denture as really a crutch. Yes, it does allow people to work and get around and have mobility. But in today's world, my philosophy is that nobody should have a disability that hinders their normal function. And I believe a fixed prosthetic device on dental implants is just like this gentleman who's been rehabilitated, a double amputee, who now can play golf and walk and be active and be engaged in sports. And there was an article in Sports Illustrated in the United States just last week on rehabilitation of athletes with these types of prostheses. And we in dentistry have the opportunity to help patients with these problems. So I think the goals are met because in dentistry, which we can't do in orthopedics, we can take out the teeth and immediately load the prosthesis. It cuts down on the overall treatment rehabilitation of the patient, the costs. There's less surgical prosthetic components, lessening of the disability of edentulosum. And as you and I talked, and we'll talk in the Q&A, we have a backup prosthesis for future emergencies, because the reality is things do break and they do have to be repaired. And if we have a conversion prosthesis or an all acrylic prosthesis, they can go and have that while their prosthesis is being repaired. So, you know, a good researcher and good lecturer should look at the literature, and I think that's part of our heritage as graduate students, to look at the literature and lectures. And there is a lot of literature dating back to 2001, 2002, 2011. A most recent article was published by Paulo Malo. It was in the Journal of the ADA, talking about all-in-4 procedures, and you can see that these procedures, following up patients over a number of years. I think Maurice, my mother's calling to make sure I'm doing a good job here. So it'll probably stop ringing in a minute. But you can see that the cumulative success rate is in the low 90s up to the 100%, and this is consistent with what the original Brandemark protocol showed as success rates in the maxilla. We also have looked at cases in the mandible, and I just mentioned that Malo just recently published in the Journal of the ADA looking at 10 years. That's the longest study going back 10 years, and he showed 93.8% success rate in the mandible. So I think that if you look at these studies, they all show excellent results using this particular protocol. There's been a lot of talk at meetings and discussion about the engineering involved with only putting implants on, putting a prosthetic device on 4 implants, and would it hold up? And when I look at this, to me, I have to look at laws, principles, and axioms. And fortunately for me, I have a brother who's a mechanical engineer, and we talk about these types of things because I don't have a background in that area. And when I show him these things, he always says, well, everything works on principles. And one of the principles of engineering that's been around for a long time, and I know Carl Misch is a strong proponent of this, is stress equals force over area. So one of the things that all-in-4 can do is you can put longer fixtures by tilting the fixture. You have greater surface area by putting long implants. Most importantly, and I think one of the biggest advantages, is you can reduce the distal cantilever on the prosthesis by placing a tilted implant. And Maurice and I were just talking before we came on the air today. There's an article here from a group in Italy doing an FEM study showing how the cantilever is affected in FEM studies by tilting the implant. And that just came out yesterday in my JOMI journal. Increased inner implant distance, and as a periodontist, that's good because the patient will have the ability to use some kind of device to clean. We don't have laboratory problems where implants are too close together, and you create a regular prosthetic polygon. And I think all of those relate to stress equals force over area. And if you look at these devices, this is one that I had an opportunity to actually work with the restorative dentist yesterday and place in the patient. This is an all-in-4 fixed prosthetic device that has acrylic teeth, customized acrylic veneering, and then it's the teeth and the acrylic is veneered over a CAD-CAM titanium Procera framework called a Montreal bar design. But the reality is these are very complex structures with different materials, and they all have a different modulus of elasticity. And as we know in the oral cavity, we have compressive forces, we have tensile forces, and we have shear forces on this fixed prosthetics. Now, what concerns me is that we want to give people, when we do lectures, some kind of analogy. And I've seen lecturers give the analogy of a bridge going across a river. This happens to be the Queensboro Bridge in New York. And somebody referenced this because this is a truss style design, that this equates to the all-in-4 prosthesis or any prosthesis that's on implants. And the truth is, they're not apples and apples. And the reason is that the engineering is quite different on these two types of prosthetics. And you know, the axioms, and I've said this always at the beginning of a lecture, is that implants are like teeth, but they're not exactly like teeth. And we know they don't have a periodontal ligament. We know it's an ankylosed tooth. We have multiple components. So we as dentists need to make sure that we change our paradigm, we change our thinking when we're dealing with implants as opposed to a tooth. That's number one. Number two, this is a picture of a traditional hybrid prosthesis, a Brandemark style high water denture on stilts or whatever. And this was a prosthesis that was put in place approximately 10 years ago. And if you look at the right side, you'll notice that there's a tooth missing. And the truth is, whether we're the greatest dentist in the world or Dr. Goldstein that works with you and Ron and you are doing a prosthesis, when we put something in a patient's mouth, it's in a state of failure the moment we put it in the mouth. Well, our hope and goal as a dentist is that it fails very slowly or doesn't fail at all. But the reality is the materials that we place do wear. And we have to be a realist when we do this and not just show the case when we just put it in and say, isn't that beautiful? So there is going to be a degree of maintenance, there is going to be a degree of repair, and I think we need to plan for that early on when we're planning for these cases. Now, one of the things that Noble Biocare did a couple years ago is they did a study. And they did it with a large number of consumers. And what the large number of consumers said when the word bone grafting was mentioned, most patients don't like to think about having bone graft. And even though we and Maurice, you do surgery, I do surgery, and a lot of people in the audience probably do too, we don't see it as a big deal. But patients see it as a big deal. So if you can offer patients a non-grafted solution for a fixed appliance, that's appealing to a patient and may meet their goals. Is it better than an appliance where you graft and put it in? I don't know. We're going to talk about that. But if you look at all-in-4, one of the advantages is it is a non-grafted solution to place implants. Tom Balshi, as I said earlier, he has a non-grafted solution that he proposed using zygomatic implants and pterygoid implants, and he learned some of this from obviously Dr. Brandemark, who was one of his mentors. And then you can look at the Algore, which is now a tilted concept, again creating a polygon. Now, one of the things you look at when you look at pterygoid implants in this V2V, you're going back into the posterior maxillary mandible where you may or may not have bone. So they may have certain situations where that may not work. But again, these are fixed, non-grafted solutions for these problems. So these structures that we make, these hybrid prostheses, they're very complex. And one of the things that I heard recently in Sweden was that you cannot use the equations of statics alone to determine load on these things. And that's what everybody wants to talk about. Well, what about the load? What if you lose one implant? the prosthetics is only on one implant, and then they apply these rules of engineering of bridges across rivers to these prosthetics, and you really can't do it because the implants are embedded in bone. We have different quality of bone, cortical bone, cancellous bone. We have different types of envelope of functions and loads and parafunction that patients exhibit on these prosthetics. So the truth of the matter is an engineer would tell you that these prosthetic devices are statically indeterminate, and an analysis that treats it as a bridge across a river is not adequate. So you have to talk about a curved elastic beam under bending and torsion. And Salick, who was one of the bioengineers who's since passed away, talked about Brandemark in his book that at the present the variables are not known well enough to be accurate enough to warrant an elaborate analysis with these appliances. Now, this article that was in JOMI yesterday that I saw and we were discussing early uses FEM, and they're actually using an anatrophic model to look at all-in-4, all-in-5 in different manners. We do have some of those things that Salick didn't have with computer modeling in the 80s, but nonetheless, these are very complex appliances. So the summary of the science that I see is it's clear that the clinical studies show good long-term success with the all-in-4 appliances equal to the traditional Brandemark appliance, which I started with in implant dentistry in '85. We also know that this is a complex structure. We can use some analogies. We can use some degree of engineering studies on these things that we didn't have before, but the reality is they're complex structures and we don't have exact science for them. So what has been my experience with dental implants all-in-4 over the years that I've been doing it? Well, let's look at a patient, because that's who we're talking about, not engineering models. And Valerie is a patient who presents to a practice similar to the patient you had talked to me about earlier, and essentially she has a failing maxillary dentition. It's not failing because of periodontal disease. What it's failing is the endoposts are fracturing. She has recurrent decay. She's on medications that have created a xerostomia, and now we have dentinal caries, which is extremely hard to control. You can see there's been some patches. Her mandibular dentition actually is fairly intact and doing much better, but it's the maxilla that's failing in this particular patient. So look at the reformatted Panorex on the cone beam. You can see, unfortunately for this patient, she has a lot of bone because we've not had periodontal disease. The sinuses are not largely pneumatized. So this patient has a lot of options, in my opinion, for this failing maxillary dentition. And again, this is a traditional MISH approach. He would like 6 to 8 implants. He might use sinus lifting if he needed it for the posterior implants. All the implants are placed in a vertical dimension, and Carl would probably use what he calls an FP3 appliance, maybe FP1 or 2, but probably FP3 to rehabilitate this particular patient. So I think for this patient, this protocol would probably work very well. Would the all-in-4 technique work? Well, based on some of the goals and criteria I've already laid out, I think all-in-4 would work very well for this patient. You'd have an excellent AP spread because the sinuses aren't pneumatized terribly forward. You can get the implants separated, a nice regular polygon. I think this would work as well. The question is, do you need second molars? Do you not? You could debate that. I think the ball sheet protocol would work for this patient. We could take the teeth out. We could place these same implants in at the time of the extraction, and the patient would have a fixed prosthetic appliances. I know people are uncomfortable with the zygoma implants sometimes surgically, but the truth of the matter is all the studies have shown it's a very successful implant and can be done properly, although they're not generally recommended for immediate load, and some of us have done that, but it can be done. And this is the V2V configuration where you again go into the tuberosity or the pterygoid area if you have the bone, and then you use an all-in-4 tilting on the one implant, and then the other implants can be vertical or tilted as well. And I think this would do the same thing that the MISH protocol did, or the all-in-4 protocol, and maybe if you have parafunction posteriorly, this might be a better thing with more implants. So it's 6 implants. Now, here's the kind of patient that we see in our practice because of the type of practice I have. This is Mary, and Mary's looking for help. and you can maybe get a hint of what's going on with Mary by looking at her clinical photographs. And when Mary takes her maxillary denture out, this is Mary's anterior view, and that was her lateral view. So you can kind of see something's going on, and here's her denture in place. She has 6 or 7 remaining anterior teeth in the mandible and a posterior wire partial. And when you take her denture out, that's essentially what you see. You don't see much of anything. And when you look at her denture, there's basically a flat intaglial surface. There's no ridge. And when you take her cone beam CT and you reformat it for a Panorex, she has no maxilla. And Mary's chief complaint is when she bites, her denture pushes into her anterior nasal spine and causes a lot of discomfort, obviously. So what do you do with this patient? This is a severe disability for this particular patient. Now, there are options. The options that have been proposed, they're really not within my scope of practice because I would work with an oral maxillofacial surgeon in this. But you can do bilateral sinus grafts and then an iliac crest onlay graft, Lefort 1 osteotomy, and iliac interpositional anterior veneer grafts because of the anterior posterior resorption. The ball sheen no bone solution is something he does with these patients. My friend Ed Bedrosian in San Francisco does the quad zygoma technique on some of these patients, or you can't do anything. And most of my oral maxillofacial surgery colleagues tell me these are challenging patients, not always met with success. They have to be kind of arm twisted to do some of these things for these people that have these severe disabilities. So my goal, my charge, my purpose of dealing with my patients and lecturing is, why do we let patients get to this state? Is it because they ignored it, we both ignored it? I don't know. So I mentioned earlier that the World Health Organization, if you look at all the diseases they list, the one dental disease they list as a disability is edentulosum. And I think that's significant coming from this organization. And they define disability as an umbrella term covering impairments, activity limitations, and participation and restrictions. This patient has a restriction in life, not necessarily in chewing. She actually has had some psychological ramifications from this. She has closed herself into the world and can't do things that she would otherwise do socially. So I think that we have an opportunity throughout the world to not allow this to happen, just like a periodontist. I don't want people to lose their teeth. I don't want them to get dental decay. The foundation of my training as a periodontist was primary prevention. So implants, in my opinion, for a total edentulous patient is primary prevention. We know that that's the only thing that's going to maintain the bone. So as a result of that, I have a philosophy in our practice. It's called no teeth in a glass. I don't believe, as Dr. Brandemark has said, any patient should die with their teeth in a glass. And that includes overdentures. And I know that may be a strong statement for people who feel overdentures meet patients' need. We know there's studies that show they are, and I'll get into that in a little bit. But I think your teeth should be in your mouth. I think either they're going to be affixed to a periodontal ligament or they're going to be affixed to a titanium implant. So this is a philosophy I have. It may be a strong position, but I feel we need to take this position in the world, just like no patient should have to walk with a cane. So what are reasons to edentulate patients? Maurice, you and I had an opportunity to be in a seminar once, and I was fortunate enough to be the presenter. And we took somebody's teeth out, which was questionable or questioned by the panel and the audience. And I thought about that a long time after we did that program. And why are there reasons to take out teeth? And I looked in various books and texts and journals and guidelines from organizations, and it was really hard to find a place where people would state, why do you take out teeth? So I kind of put this together. These are reasons I see using John Coyce's risk assessment, that the risk assessment's high and therefore you might want to take out a tooth or teeth. Diabetes, recurrent aggressive perio, previous periodontal surgery is considered to be a risk factor for additional support attachment loss. Genetics, I've already showed a case with root caries. We've seen radiation caries. I see a fair amount of Sjogren's syndrome patients. Unfortunately, in our community, we have a lot of meth labs, and it's been talked about meth mouths where patients lose their teeth due to the addiction. Function, we see severe bite collapse, poor occlusions, either in their natural teeth or in previous prosthetics. They're non-functional, and they don't think rehabilitating it will necessarily give them better function. And in the case I showed earlier, it could be due to poor cosmetics, defective dentistry, not intentional defective dentistry, but dentistry that's just failing for the patient. Or they've had multiple endos, and the endos have not worked for the patient for whatever reason. So I would see those as reasons, valid reasons to take teeth out. I think some of these are pretty obvious, pain and suffering. We see patients all the time who have tried to keep their teeth, want to keep their teeth, but they've caused so much pain and suffering they can't. There's a debate between what's the higher cost of rehabilitating the patient versus taking the teeth out and doing an implant prosthetic device. In today's economy, in the United States, throughout the world, it may be more expedient for economic reasons to do these type of treatments. The worst and sometimes most difficult ethical decision we have to make as dentists is when the patient, through their own autonomy and informed consent, wants to have the teeth taken out. There are cases where, Team Atlanta might say we could do a perio prosthetic device, more to Amsterdam type, rehabilitation like you learned at Penn and I learned at UMKC. But the reality is, at the end of the day, is the patient going to be better off? And how much are they going to have to go through time-wise, money, expense, local anesthetic, general anesthetic, surgeries. And all the above are reasons why sometimes patients want, to have their teeth taken out. So these are just some of the reasons I came up. Maybe there's more. Maybe you'll have some ideas in the Q&A. Here's a patient. This is typical of patients I see. She's 51 years old. She's had dentures since she was 26 years old. She's on her 5th set of dentures, and not one of the 5 previous dentists, which are all dentists in the community, no one has mentioned dental implants to this patient. So she goes to the 6th dentist, and the 6th dentist admits to her he can't make a denture any better than the previous 5 dentists, and the only way her problem is really going to be solved is with dental implants. Now, when you look at this patient's maxilla in a clinical photograph and in the cone beam, you can see on the photograph it may not look like a challenge, but in the cone beam CT, it's going to be a challenge. So if there ever was a truism, don't judge a book by its cover, I've seen cases where the ridge looks great, you take the cone beam, it looks horrible, and I've seen clinical patients whose ridges look horrific and you take the cone beam and they look good. So you cannot judge a book by its cover when you're looking at these cases, but you can see, you would think she'd be able to wear a denture. She can't. She's obviously got severe resorption in the canine regions, and many times that's because when the canines were removed, probably the buccal plate came out, and now this is the resorptive pattern that she has. And look at her lateral view. She's a very attractive lady. Her mid-face is starting to collapse. She's starting to have problems chewing and eating. She hasn't gotten to the degree that Mary has gotten, but her perception is that she's prematurely aging. From a medical history standpoint, she's perfectly healthy. She has no diseases. So if the World Health Organization is correct, I see this patient as a disabled patient. And I think we have the opportunity to treat this patient. I wish we could have treated her at the 1st or 2nd denture stage because I don't think it would be as complicated. But the truth of the matter is this is premature aging. So dentures aren't the solution. They're part of the problem. It is a crutch. We do have 2 different clinical routes, and I use both of these clinical routes to do the all-in-4 procedure. The one that I prefer and like to do the most is using a computer-aided guide to place the implants, but this does require the teeth either to have been removed prior, or you have to remove the teeth, let the patient heal for a period of time to do it. But this is my favorite type of surgery to do for the all-in-4 patient. Or we use a all-in-4 template or a malleable guide to place the implants, and we'll talk about both of these techniques in just a second. So there are 2 different ways to do the procedure. This is the malleable guide. You drill a small osteotomy in the midline, and then this guide can be bent to conform to the arch form, whether it's tapered or round or square. And then the guide has some markings on it. They're 7 millimeters apart, and the guide's approximately 10 millimeters high. And so this guide can be used to do what I call analog implant placement. Now, why do I like computer-aided surgery? It enhances planning accuracy for me around the sinus and the nerve, although I'm not hesitant to identify the sinus or the nerve surgically. It does improve patient comfort. My analog flap type all-in-4 surgery probably takes 45 minutes to an hour. For this particular procedure, it takes about 20 minutes. Yes, it does take more time preclinical to plan it, but I like that efficiency for the patient comfort. Accuracy in the fixed prosthetics. That's really why I like to do it, because I can see problems, nuances, angles in the software that I can't see or necessarily overcome when I'm doing analog surgery. So if I can give the laboratory or the restorative colleague the opportunity to solve problems in advance and come to solutions in advance, I like that. All patients want everything to look good, and ultimately the implants are the foundation, and if we can put them in the proper position with good angles, I think we can get good aesthetic outcomes for our patients. So I'm a big fan of computer-aided surgery. Now, this is just, I went back 5 years, because 5 years ago is when I started doing guided surgery. That's when Nobel came out with the Nobel Guide technique. And you can see in this table that I don't do the same procedure for every patient. I use all of the protocols that I previously outlined in some slides. I do MISH protocols, I do the Malo technique, guided all-in-4, the ball sheet technique, the traditional Brandemark technique is still one of my favorite techniques in the mandible, where we place 5 implants from foramen to foramen. In the mandible, we've done all-in-4 technique. So I have multi-styles, and we've been very successful. The reason I think we've been successful, I've had good training, I've had great mentors. I am picky in following protocols. If it doesn't achieve a certain level of torque, I'm not going to push it. Patients can still have 2-stage protocol procedures and wear dentures over the implants, and then we do a traditional protocol of prosthetics. So fortunately, I've had an opportunity to have great success with these procedures, but we don't do one procedure for every patient. We tailor the procedure to the patient's needs, to the restorative dentist's needs, and ultimately we've been very successful. So I'm happy to report this information. Now, what are the issues that I see when I see failures? One of the reasons is there's no diagnosis. We all know this as clinicians, that if you don't diagnose properly and you try to do things in a haphazard manner, I call it design build philosophy, or my brother who's an engineer calls it design build, there's always problems with design build. The other is there's not adequate evaluation of the smile. Patients are not coming to us for implants, they're coming to us for teeth that are in function and teeth that look good when they smile. And if we don't look at the smile characteristics of the patient, and you and your practice, Maurice, in Atlanta, and Dr. Goldstein were the pioneers, and really I thank Ron for enlightening us surgeons on smile characteristics. I think it's great. One of the biggest problems with all-in-4 or any of these procedures is there's not enough bone reduction at the time of the extractions. And what this leads to is big time laboratory issues. You can't set the teeth, you can't make bars, you can't set the teeth over bars, and what this leads to clinically is delaminations, fractures of prosthetics. And that is a big problem for patients, and that's a big problem for our lab, and the last thing we want to do in the middle of the day is have one of those show up in our practice. With cone beam CT technology that I have in my office and guided surgery techniques, I believe that the days of surgical voyeurism are over. And what I mean by surgical voyeurism is when I used to have to tell a patient from a Panorex, look, we're going to have to open you up so I can see what this looks like, and then we're going to figure out what we're going to do. Having had some surgery a couple years ago myself, I looked at the surgeon and said, can't you do something to figure this out before you do it? And he said, we do. And so they did, and the surgery was very successful. So in dentistry today, we can do this without surgical voyeurism. The next is no training. I don't think I'm going to give you enough information today to let you do this or have anybody do it, and that's why we have courses and give courses. So you need to get the training. You need to take your laboratory to the training sessions. They sometimes go it alone, so I saw Pincus here today, you know, he would say that's 100% true. And sometimes we're just stuck in our paradigms. I would say to some degree I was stuck in the traditional 5 on the floor, Brandemark hybrid type prosthesis, not a profile prosthesis. And I had to have my eyes opened a little bit, read the literature, go to lectures, go to conferences, and I've changed my paradigm. I do believe the all-in-4 is a good procedure for patients. So we got to be open. We got to be open to the literature. So those are big issues that I see with clinicians. Are there complications? None of us like to have them. None of us like to see them. I have seen, unfortunately, some complications from practitioners placing all-in-4 implants. One was a fractured mandible. I think the implant perforated the border of the mandible. This was using Noble Active implants. It's not the implant, it's the archer. And unfortunately, this lady's mandible was fractured. And again, whether you're doing it analog or you're doing it with computer-aided guide, we need to stay away from vital structures. And in this particular case, there was a cutaneous neuropathy of the mandibular canal, and the patient had a subsequent permanent paresthesia. So good technique is still important regardless of how many implants we're placing. Yes, there are prosthetic complications. We need to be aware of them. The most common, I said, is veneer fracturing, and I think that's related to inadequate bone volume reduction and laboratory support. Common things we see is abutment screws loosening, abutment screw loosening, prosthetic screw, prosthetic fracture. The conversion prosthesis fractures. This is a patient who fractured his conversion prosthesis. Again, that's not a catastrophic failure. It's an inconvenience failure. We actually make a surgical repair guide at the time of the surgery, so it's very easy to repair this, but people do break them. The framework fractures, I think in today's world with CAD-CAM titanium frameworks, alloys, that's going to be very unusual to fracture a framework. Material fracture and wear, common. If we're using acrylic teeth, they're going to wear. So again, not a catastrophic failure, it's something part of dentistry. So in summary, my experience with the all-in-4 procedure and the other type of procedures with all immediate loading has been excellent. It is part of my bag of tricks. It's one of the clubs in my bag, if you want to use the golf analogy. We don't use it all the time, but when it's appropriate, we use it for the right patient. In evidence-based care, I think the thing that doesn't get played out very often is what's the patient experience. We can quote the literature, we can show our history, we can talk about the bioengineering, but you know, what are our patients getting from these procedures? And we all know that for patients, I think the 3 biggest issues are time, money, and value is probably the most important. And all of the patients that we've had an opportunity to help with this have gotten great value. And what John Coy said a few years ago, which was a great statement, was what our patients really want is no dentistry. I mean, if they could have their teeth made beautiful without veneers and bleaching and crowns and, you know, orthodontics and all this, they would go for it. And probably rightfully so. And I think as a periodontist and somebody who does surgery, for sure patients don't want surgery. Or for sure they want less surgery. I mean, if I went over to a mall over here and set up a booth and said I'm giving away free surgery, I doubt it, unless it was maybe some cosmetic surgery, that they'd do it. So I don't think patients want surgery, and even though we're surgeons and periodontists, and that's what we do and we're comfortable with, the truth is our patients don't want it. And there actually was an interesting study that was done, a review recently on the quality of life with dentures. And this was a JADA supplement in 2011 done in conjunction with the Prosthetic Academy. And they looked at these things and they found a lot of things. And one of the things that touched me is that complete edentulous and complete dentures have a negative impact on the quality of life with patients. There's no evidence to support that adhesives work that well. We know there's denture stomatitis. There's going to be a correlation between bone resorption and the longevity or the length of time that patients wear dentures. And they also did a study that showed, because sometimes people who are into dentures say, well, I make a good denture, or the teeth that I put on my denture chew better than this guy's teeth or that person or this lady's teeth. Well, the truth of the matter is no posterior tooth design is shown to be more effective than any others. Also, in 2010, a study showed that overdenture patients were less satisfied than fixed. Do I do removable appliances in our practice? We do. We do it when the patient's autonomy and decision is to do removable, or in the case of the referral, they want to do removable appliances. But the truth of the matter, regardless if it's a fixed appliance or it's a removable appliance, most of our publications, over 8,000 on dental implants, fewer than 2% of these studies actually asked the patient what was the best for them. And it would be interesting if somebody would do a study with a bunch of patients where you give them a removable appliance and a fixed, let them try it for a period of time, and then do a patient satisfaction study. So, but we do know that people with overdentures, a lot of them are satisfied, and it does meet their needs. But in my world, I think a fixed appliance is probably the best. Now, this is a interview with a patient who had a all-in-4 procedure, and you're going to listen to her comments relative to the all-in-4 procedure, and let's just listen to her. How do you think this treatment has improved the quality of your life?
Before I had the treatment done, my teeth were loose. Not probably loose, they were loose. And like they would come, the top ones were, some were lower and some were higher, so it looked silly. There were lots of gaps in my teeth. Since I've had the surgery, I feel like my mouth is healthier. I can eat apples, I can eat an ear of corn, and it's great.
What advice would you give to others who are considering treatment in Dr. Duello's office?
There is no, and take it from someone who was very nervous when this all started, but after being through it, it's nothing. It's a piece of cake. And you come in for the surgery, he does it, you go home. I slept for a while. The next morning I got up and was able to do my normal activities. There was no really recovery or any bad things that had happened to me since when I had the surgery.
And I think, this video highlights a couple things. This particular woman's goal was to go down the aisle with her daughter at her first daughter's wedding and look good. And she did not feel good about how she looked. And this was an important event in her daughter's life and her life. And we were able to do the things I've talked about earlier: expedite treatment, remove the teeth, put the implants in, do an immediate load protocol, give her a screw-retained fixed acrylic prosthetic device that allowed her to smile and be happy. And if anybody's done this type of treatment before, you can see it in the patient's eyes. You can see it in the patient's demeanor. You can see it in their personality. They have a transformation. So the question always comes about, well, whether it's a patient or a referral, how much does this cost? And I answer that: what is the value of the treatment of the incurred cost of the therapy relative to the rehabilitation of the patient? And if you've been doing this for a long time, I always do this with patients that we do follow up on. About 5 or 6 years after we've done it, I ask them, do you remember what you paid for this? Rarely does the patient say anything about what they paid for it or remember. And the other is that I ask them, if we could take it away from you and you didn't have it, would you let me take it away from you? And they all say no. It was the greatest thing that I ever did, one of the best things I did for my health. So I think sometimes we get hung up on the financials, and sometimes that has a play on whether you do a removable or you do a fixed prosthetic device. I try to create a lot of value for the fixed prosthetic device. I think it does give the patient more value. I do believe it gives the patient more satisfaction, and that may be a paradigm and bias I have. So I tend to make the opportunity possible for the patients, and my practice hopefully is known for that. So patient values, I think they're extremely high, and this is why I got involved in this particular area of implant dentistry, because the most rewarding patients that I have ever treated are two: the total edentulous implant patient and the patient who is a periodontal cripple, and you save their teeth. So patient values are very high for these procedures. So in summary, we've looked at three things. We've looked at evidence-based care, we've looked at the literature, we know internationally that All-in-4 works, no matter where it's being done. My personal clinical experience with All-in-4, when it is the appropriate technique or modality for the patient to treat total edentulism, it has worked very well. We are extremely proud and honored that Noble Biocare has allowed us to do things with them and provide these in our community. And most importantly, in our community, the patients and the referrals we've done this with have received great value and continue to refer patients for these particular procedures. So I think I'm very happy. And the paradigm shifts some of us have to come to, because I do lecture, I can tell you in many places in the world, people are still not doing immediate loading. They don't think it works. Well, it does work. 4 implants don't work. It can work when it's the right prosthetic application. Guided surgery doesn't work, absolutely does work. I love it. It's my favorite modality of doing it. One of the big hang-ups that people have with fixed appliances, you need a labial flange to have lip support, lip seal, phonetics. I had a paradigm change with that with one of my mentors, Steve Perrell, in Texas, and the truth is not every patient needs a labial flange, because his opinion, others' opinion, is the cervical third of the tooth that gives the anterior lip dynamics. Paulo Malo started a lot of this in Lisbon, and he's very successful there, as the ADA article said. But the truth of the matter is it works everywhere, and works in St. Louis. Hopefully it works in Atlanta with you guys. So these are some of the paradigm shifts that I had to go through. I'm over these. These are routine ideas and concepts that we have in our practice. And a couple years ago, I had an opportunity to go to Sweden and be with Dr. Brandemark with some of my friends and colleagues. And one of the things that Dr. Brandemark said to me personally and said to us from the podium is, there's a lot of things going on in implant dentistry, but for me, I hope that we, the clinicians who take over in the future, simplify things and make them more reliable for patients. And if All-in-4 is efficient and effective and reliable, I think this would meet the grandfather of osseointegration's criteria that he set out 2 years ago for us clinicians to implement with our patients. So I'm honored to have had a history with him, and hopefully we're living up to this charge that he gave us as clinicians. So I hope that was helpful to the audience today.